Good evening and a very warm welcome. Happy New Year to everyone who has joined this webinar on Oncology Update 2025. I welcome you all for this webinar, and with immense pleasure, I would like to invite Dr. Sahil Gupta, who is Consultant Department of Medical Oncology at Kailash Cancer Hospital and Research Center, Vadodara, Gujarat, for the welcome and introductory note. Over to you, sir.
Thank you. Good evening, everybody. I'm delighted to welcome you all to today's academic meeting. We are fortunate to have a senior oncologist here with us to share their wealth of experiences and knowledge. As we embark on this intellectual journey once again, and hello, am I audible?
Yes, sir.
So, with that, I would like to start this meeting. I would like to invite Dr.
Sorry, sir. Dr.
Hello.
Pritesh Mohanty, Dr. Pritesh will join after some time. There is some issue with
Okay.
him. So,
So,
can I invite you for your Merck session?
sure, I'll take my session.
Okay. So, I would like to invite Dr. Sahil Gupta for his session on Javelin Bladder Trial. The session is sponsored by Merck. Over to you, sir.
Thank you very much. I'll just start my screen sharing.
Sure.
So, is my screen visible?
Yes, sir.
Okay. So, good evening, everyone. So, the topic that I'm going to take is the role of avelumab in management of urothelial carcinoma, basically in the locally advanced and the metastatic setting. So, these slides are provided by Merck. So, urinary bladder carcinoma is comparatively more common in the northern parts of India. It's a very bad disease to have. The patient population is usually between 55 to 60 years of age. At diagnosis, the patient generally have muscle invasiveness, and usually the nodal invasion has already occurred in 50 to 60% of the cases, and 40 to 50% of the cases that present to us, they are at a metastatic stage. So the advances in the locally advanced or metastatic urothelial carcinoma. So we can see that in 1965 it started with the cisplatin, and in 1985 MVAC was introduced, and in 2000 the combination of gemcitabine and cisplatin was comparatively found as effective as MVAC chemotherapy regimen. In 2006, the patients who were not eligible for cisplatin due to any circumstances, due to renal failure or peripheral neuropathy or low creatinine clearance or due to age or due to cardiac issues, carboplatin was given as an option, but currently the literature says that cisplatin cannot be this replaced by carboplatin. In 2009, vinflunine was added to the armamentarium. And in 2016, we started with the era of immune checkpoint inhibitors with atezolizumab, and 2017, pembrolizumab and nivolumab. In this, atezolizumab has been withdrawn. It remains as a category 2B recommendation in the NCCN guidelines. And durvalumab has been withdrawn from the second line also. Pembrolizumab continues in this ineligible patients for cisplatin eligible patients. And nivolumab has been stated as the first line treatment also in conjunction with avelumab in the first line setting. So the platinum containing chemotherapy, generally they have a good response rate. The patient, when they present with hematuria and sometimes bladder outlet obstruction, the response rates and the disease control rates are high in the range of 75 to 80%. But since the population in which the disease presents, the age is approximately 55 to 60 years, the tolerance to cisplatin is questionable, and it is very difficult to tolerate this for these kind of patients. Generally, the progression-free survival on chemotherapy lies between 3 to 4 months. And initially, after giving first-line chemotherapy, there is a response, and we used to wait. We used to give a wait on watch therapy, or we switched to single-agent gemcitabine. But there was disease progression early on, and the condition of the patient deteriorated. Especially gemcitabine maintenance and cytopenias were and asthenia were major problems. And then the second line therapy was initiated, but the prognosis of this cancer remained poor, with a median progression-free survival total being 6 to 8 months and a dismal overall survival between 13 to 15 months. Over here, the quality of life of the patient was also deteriorated because of the cytopenias. So, is there any role of immunotherapy upfront? Uh, let's see. The overall survival, as we compared with platinum-based chemotherapy versus the upfront immunotherapy, there have been trials including durvalumab, the nivolumab, and the this atezolizumab, the Danube, Keynote, Pembro, and the atezolizumab with IM Vigor trial. There is not a significant improvement in the overall survival. You can see that the graph are roughly touching together, and there is no separation between the graphs, though no definitive separation between the graph. So coming to the combination of chemotherapy plus immunotherapy, uh, this timeline has I have explained. So recently in 2019, enfortumab vedotin, avelumab first line maintenance, and the combination of pembrolizumab with EV has been there, and the combination of gemcitabine with nivolumab have been mentioned as category 1 recommendations. So there has been a concept of switch maintenance in which we give first line chemotherapy, we get the response, and we start switch to immunotherapy agents as seen with avelumab, and then after the disease progression or unacceptable toxicity, we go for the second line therapy. The rationale being chemotherapy, it decreases the tumor burden and increases the immunogenicity of the tumor microenvironment. Bladder carcinoma is already a tumor with a high tumor mutational burden. So with chemotherapy, new antigens are released and the immunogenicity of tumor is increased. So immunotherapy is comparatively more effective in patients who have had a partial or complete response to the tumor. So coming to the pivotal trial of Javelin Bladder 100, in this, the patient with unresectably locally advanced or metastatic urothelial carcinoma were randomized, and they should have received first line standard chemotherapy of 4 to 6 cycles of gemcitabine plus cisplatin or carboplatin. The patient were randomized to patients with complete response, partial response, or stable disease, and they were randomized to avelumab or best supportive care. The primary endpoint were overall survival, and the primary analysis population with ITT population and PD-L1 population. The secondary endpoint with being progression-free survival, overall survival, the overall response rate, time to response duration, disease control, patient-related outcomes, and safety and tolerability. So here we can see that the median OS measured from the start of chemotherapy, the difference is approximately 10 months, and the graph are continuously separated. The number of patients was equal in both the arms. There was a 10 months improvement in the overall survival and a 23% reduction in the risk of death. So when we see that the disease control we have achieved with platinum based chemotherapy, and the patient were randomized, approximately 43 patients were still on the first line therapy, and 307 patients who continued the first line therapy, and the subsequent drug therapy included either a PD-BDL1 inhibitor or FGFR inhibitor or any other drug, including antibody drug conjugate. We can see that the avelumab, 5.9% of the patient with subsequent treatment, they received a PDL or PDL1 inhibitor. And in the best supportive care arm, 73% of the patient had treatment with PD or PDL1 inhibitor. It has been found that the patient who have received FGFR inhibitor or antibody drug conjugate like and photodamaveditin, the survival rates were pretty much higher as compared to chemotherapy. So when we go accordingly that after chemotherapy, the patients have received a PR, CR, or stable disease. When we put them on avelumab maintenance versus no therapy, we can see that the median PFS was 5.5 months, and the in the avelumab arm, and the best supportive care arm, the median PFS was 2.5 months, and we can see that the graph are pretty much separated, and they continued to do so after 3 years. The hazard ratio for the for as comparison to the both the arms, it was an impressive of 0.54. So coming to the adverse events, they were pretty much manageable. They were the the incidence of grade 3 events was comparatively less, and the tolerable and manageable, also manageable in the avelumab arm. So these were basically diarrhea, hypothyroidism, pruritus, related reaction. In my practice, I have seen only ILD and this asymptomatic hypothyroidism and decrease in the cortisol levels, which were asymptomatic, for which I have not, it is not required, it was not required to decrease the dose or increase the steroid requirement or giving a break to the patient. So we can see that when we see that when we compare the avelumab maintenance, when we see that the patient either has received carboplatin or cisplatin, either we can see that the carboplatin cannot be is not an alternative to cisplatin. We should go for cisplatin. Only in cisplatin ineligible patient we should go for carboplatin. So over here also avelumab fared better as compared to the other arm, and in carboplatin arm, the improvement was not as much, but it was still significant. So as we have seen that the in the trial, 4 to 6 cycles of chemotherapy has been mentioned. So here we can see the irrespective of the number of cycles of chemotherapy, the overall survival benefit was maintained. The hazard ratio was impressive of 0.69, and it was a slight better in the 6 cycles of 0.66. Generally, what I prefer is I usually go with 4 cycles of chemotherapy because of the cytopenias related to gemcitabine and this cisplatin related toxicities, and as these patients are elderly patients. Now, when we see that the time to response evaluation, whether we have done between 4 to 6 weeks or more 6 to 8 weeks or 8 to 10 weeks, we see that the hazard ratio and the benefit is maintained in all the subgroups. The hazard ratio is in the line of 0.65 to 0.75 in most of the subgroups. So coming to most of the data we have is for the Western, but when we analyze the Asian subgroup of the patients, uh, the patient they were the in that particular javelin bladder 100 trial, the Asian subgroup comprised of approximately 147 patients, and there were the arms of randomization were pretty much balanced. The primary endpoint included OS, and secondary endpoint were PFS, response rates, and safety and tolerability. So, coming to the Asian patient, we have seen that the response was pretty much maintained. The OS benefit was there, and that was roughly equal to the seen in the overall trial. It is 28.7 months versus 29.2 months in the overall population, and the PFS is roughly equal to the overall population. So we can see that it is also working. It is these data in the Asian patient is as good as in the Western patients. So coming to the duration of the drug, so avelumab is a costly drug. So what will be the is there any specific time till which the benefit will be obtained if we stop the drug at 1 year or 2 year? In studies, it has been seen that avelumab maintenance, at least for more than 12 months, the PFS and the overall survival was comparatively better, at least, and it should be given for at least 1 year. The benefit is maintained because logistics being a big issue in India. Coming to the real world evidence, uh, we can see that the in various countries like United States, France, Italy, the progression-free survivals are roughly same, except in the Italians have fare much better in the in the geography, and the overall survival rate was 70. The 12 months overall survival rate was 71 months, 71.3%, which is in line with the Javelin 100 bladder trial data. The survival outcomes was also pretty much similar, and with over here also the Italians faring a little bit better. So Evanan's study, which was a study done in France, the patient were included. The inclusion criteria with the patients had previous or ongoing or planned first line avelumab that did not progress after first line of platinum based therapy, and the exclusion criteria included the patients who were investigated in the clinical trial. The primary endpoints was overall survival, the secondary endpoints with PFS, the duration of response, safety. So here we can also see that the median OS was approximately 26.3 months and the PFS and was approximately 5.7 months. The 1 year OS overall survival rate was 66% and the 2 year survival rate was 46%. So we can see that the Javelin Bladder 100 trial data and the real world evidence in France in the evidence study, they are showing the equal results, roughly equal results. So coming to the what the percentage of the patient who received second line treatment. So most of the patient they received enfortumab vedotin in the antibody drug conjugate arm. The chemotherapy was given in 73.9 patients, and 23.5% patient did not take further treatment. And where we can see that 21% of the patients, after median follow-up for 26 months, they were still on avelumab. So in this, in 20% of the patient, the after 26 months also the response was ongoing. So here we can see that the patient who had taken enfortumab vedotin, which is an ADC, the median overall survival was reaching up to 40.8 months. This 1 year old survival was 97% and the 2 year old survival rate was 81%. So avelumab maintenance and the switching to second line in ADC with enfortumab vedotin is the best way to go forward. Although 10% of the patient being FGFR3 positive, erdafitinib can also be an option, but I think it's not available in India till now. So, in there was similar study done in Japan, and approximately the overall survival was approximately same at 40 months with the patient at in the enfortumab vedotin arm. Important here is see that the patient who received platinum-based chemotherapy and second-line pembrolizumab followed by enfortumab vedotin, the survival was 24.7 months as compared when the patient received platinum-based chemotherapy according to the Javelin bladder trial, followed by the enfortumab vedotin. So we can see that upfront putting the patient on this avelumab maintenance and then switching out to enfortumab vedotin resulted in a impressive overall survival rate of 40 months. So here we can see that the other immunotherapy agents that have been trial, including atezolizumab, pembrolizumab, and the nivolumab. Only Checkmate 901 was a positive trial, and the median overall survival over the control arm, the gain over the control arm was 2.8 months, as compared to this 4.7 to 5 months in the javelin bladder trial. So coming to the details of Checkmate 901 trial, the patients were at least more than 18 years old. They were previously untreated, unresectable, or metastatic urocellular carcinoma, cisplatin eligible patients in which, and important to notice that in the javelin bladder, the patients who were cisplatin ineligible, they were also included. So in Checkmate 901, comparatively fitter patients were included. So the design was roughly the same. The patients were given combination of immunotherapy plus gemcitabine, cisplatin, and followed by monotherapy phase of nivolumab. The primary endpoints were overall survival and progression-free survival. The secondary endpoints were overall survival and PFS by PDL1 analysis. And the exploratory endpoints were overall response rates and safety. So the efficacy, progression-free survival, when we see that as compared, there was a point zero, like approximately, the PFS was increased from 7.6 to 7.9, 7.9 as compared to the GemCis chemotherapy arm, and the overall survival was increased from 18 to 21 months. So there was a oral this benefit was approximately 2.8 months only, and the addition of 9 days of PFS after 7 months of treatment. So this is although cross trial comparisons are not to be done, but the combination of nivolumab with chemotherapy upfront followed by nivolumab maintenance, it can be said it is not as superior as the combination of the chemotherapy followed by the avelumab maintenance. So coming to the comparison between javelin bladder and the Checkmate 901. So uh, the patient should be platinum eligible in with either with cisplatin or carboplatin. In Checkmate 901, only cisplatin eligible patient were taken, and the median follow-up was done in 38 months as compared to 34 months in the Checkmate trial. The survival was also inferior as compared to the Checkmate 901 trial, and the grade 3 adverse events were also less as compared to the Checkmate 901 trial. And we see that on progression after first line maintenance of avelumab, when the patient was switched to enfortumab vedotin, the median overall survival was reaching up to 42.6 months. So we can see that the overall median overall survivals, when we see across the spectrum of treatments that we have for metastatic or unresectable urothelial carcinoma, according to the Checkmate 901 survival, so overall survival was 21.7 months. Javelin bladder, it was 30 months. EV plus Pembro, it was 31.5 months. But in cases of first line, the patient who were randomized to the Javelin bladder trial regimen followed by second line enfortumab vedotin, the real world evidence and they approximately show that the overall survival was approximately 41 months. So to summarize that platinum-based combination chemotherapy is the first line recommended for platinum eligible patients. Here it is important to see that most of the trials the Checkmate 901 did take only cisplatin eligible patient, which was comparatively fitter patients. The Javelin bladder took the cisplatin ineligible patients also. The unprecedented median OS of 40.8 months when the patient is switched to enfortumab vedotin is a very good figure to look at. Sequencing of available agents is the key to managing urothelial carcinoma in the locally advanced, unresectable, or the metastatic setting. Avelumab maintenance treatment is the category 1A recommendation by NCC and ESMO guidelines. And the real world evidence, when compared with Javelin Bladder's trial, they show similar results only. So I had an experience with one of my patients who was on avelumab maintenance for urinary bladder. So that patient he did good for approximately 1.5 years, and the patient was FGFR3 positive and he was HER2 positive. So FGFR3 was not available in India. So the patient was HER2 positive though. So I switched the patient to TDXT, and it has been approximately it is reaching up to 2 years that the patient is doing good, and he has a performance status of 2. He's able to carry out his daily day-to-day activities. So again, saying that the sequencing of available agents is the key to managing and prolonging these survival rates and the PFS and the quality of life in these subset of patients. Thank you.
Thank you so much, sir. Now I request you to kindly invite the next speaker, please.
So I would like to invite Dr. Satyam Sathar to throw some knowledge on the transforming patients in advanced HCC, transforming the patient outcomes in advanced HCC. Sir, over to you.
Thank you so much, Dr. Sahil, and thank you organizers for giving me this platform to speak on HCC and what is the sorry. Are my slides visible?
Yes, sir. They're visible.
Okay. So I'll start with uh, basic epidemiology about HCC. So it is the seventh most common cancer globally, and it is the fourth most common cause of cancer-related mortality in the world. 45% of cases diagnosis occurs late. Uh, Either it has spread to lymph nodes or metastasized, and the obvious reason for that is that liver parenchyma is essentially a pain insensitive structure, so it does not cause much symptoms when it is small, uh, and it is very obviously presents late because of if screening is not done, if the patient is not having any chronic liver disease, there's no reason it will be picked up earlier. And as expected, the survival decreases as the stage goes up, and distant mets, the survival 5 year survival rate is as low as 2.4%. For regional disease, in the tunes of 10.6%, but we all have experienced that HCC for Indian patients, I guess, somehow is behaves very aggressively, and very few of our patients make it into the third year. That is what I would like to believe. For India, it is the 11th most common cancer and 8th most common cancer related mortality, and it is the second most common cancer death in men. If we take oral cavity as a subset, then perhaps it's the second most. Uh, if we don't take that, then it will be the third most. If head and neck is the most common, followed by lung, and followed by uh, HCC. And it is more common in males with a male to female ratio of 4:1. And incidence of HCC in cirrhosis in India is 1.6% per year. And in India, because of lack of awareness and tendency of our patients to ignore their symptoms and ignore doctor's advice and be a little ignorant about it, this leads to the fact that 50% of HCC patients present at an advanced stage. So etiology-wise, if we look, there are certain factors which cause an insult to the liver cells, which then they respond by causing regeneration and inflammation, which becomes chronic, leads to fibrosis and cirrhosis. This is the essential mechanism for cirrhosis of liver, and these are the mechanisms that lead to development of HCC. So the factors which are responsible for cirrhosis, the risk factors, are the etiological factors for cirrhosis, HCC as well. Interestingly, and we'll see in the coming slides why it is important, there is, as with other malignancies, there are mechanisms which leads to loss of immune control of the cells, which is known as immune escape or evasion. So one of the mechanisms are CTLA4 and PDL1, and other is inhibition of antigen presentation. So again, essentially the same thing, but importantly, this one, what we encounter frequently is alcohol, viral, and NASH. Patients who cannot be classified into alcohol and viral. What have been observed frequently now, what have been observed in the recent years is that, and it has been substantiated by some studies. If you look at the etiology, the most common etiology now in India is NAFLD, non-alcoholic fatty liver disease, and that is followed by viral hepatitis B and C. And we'll see why this is important, why etiology is important, because it also has a bearing on the biology, which in turn has a bearing on treatment, and that has been seen in the clinical trials that have been conducted with regards to HCC, that etiology has a bearing on the treatment or response of the treatment. So, as far as management of HCC is concerned, it is a very huge domain, although we are not seldom able to help the patients beyond a certain point, but treatment options are aplenty, and all depends upon the size of the lesion, the extent of the liver involvement, the liver function, and the spread of the disease. So we are all familiar with the BCLC. So it divides the disease into stage 0, early stage, that is A, intermediate stage, that is B, advanced stage, that is C, and terminal stage, where the function of liver is compromised, that is D. So options are local therapy, loco-regional therapy, and systemic therapy, and transplant. So based upon the patient profile, the disease profile, the functioning of liver, we would chalk out a plan, and that the treatment might involve resection of the lesion, ablation in the form of radiofrequency or SPRT. If there are more than one nodule and they are not amenable to resection or ablation, they can be given TACE or TARE. If they fit into certain criteria, they can be offered transplant. But most often, in our experiences, we will agree that most of our patients do end up getting systemic treatment, which is reserved for stage C. But most of our stage B patients would also be receiving systemic treatment. So systemic treatment has evolved over the years. Previously, we only had sorafenib 10 years back. Then came regorafenib. Then we had the entry of immunotherapy. Yes. So 2007 to 2017, the 10-year period. So we can see that this is the time when I was doing my residency, and any HCC patient meant sorafenib. So 2017 and HCC used to be a very easy chapter to as a part when back in 2014, because there was only one drug, that is sorafenib. Then fortunately the scenario started changing and we had newer drugs coming. First it was regorafenib, then lenvatinib with pembrolizumab, then came cabozantinib, ramucirumab, and in 2020 a breakthrough when the role of atezolizumab bevacizumab was established along with nivo-ep, and in 2022 The role of tremelimumab and durvalumab, with tremelimumab given in the single dose. This is what our focus will be today.
Uh, Hello.
Yes, sir.
Uh, is there any this problem with the
Maybe
sharing or
maybe sir's network will
yeah,
like just call sir.
yeah, please. So, meanwhile, when Dr. Satyam joins, I would just like to share my experience on two patients on hepatocellular carcinoma. These patients, they presented to me in BCLC stage C, and their child status was B. So, these patients, they had cirrhosis of liver, they also had portal hypertension. So giving them the combination of atezolizumab and bevacizumab, it proved a little bit challenging for me because of the bevacizumab component. So I started one patient on the combination of durvalumab and tremelimumab. The patient did not have any this adverse effect of hypertension or proteinuria. But the patient is still doing good after 3 to 4 months. The response is there. There is approximately 20 to 30% decrease in the tumor burden. So, on evaluation, in cases we have the patient with portal hypertension, esophageal varices. So, durvalumab and tremelimumab is, I think, the only option in these patients.
Sir, can we start sir's initial session?
Okay, okay. I think there's a problem with the network for Dr. Satyam. So, moving ahead, I would like to invite Dr. Manish Jain. Sir is a senior medical oncologist from Ruby Hall Clinic. I would like to invite him to share his thoughts on HER2 low malignancies. And routinely, we are getting HER2 testing done in most of the cancers. Initially, it was just limited to the breast cancer. Now we have expanded the indication to biliary tract cancers also, and gastric cancers, esophageal cancers, and in rare cases, we get a HER2 positive tumor in these colon cancers also. So, sir, I would like to invite you to share your thoughts on treatment of HER2 low malignant tumors.
Can I complete my
Yes, sir.
talk?
Yes, sir. Yes, sir.
I'm
Yes, sir.
sorry. The
Yes,
the
sir.
internet got disconnected somehow. I don't know.
Yes, sir. Please, sir.
I'll start. I'll. So is it visible? Am I audible?
Yes, sir.
Okay. So the concept of combining atezolizumab and bevacizumab was substantiated by this particular study, and it was the patients were randomized in a ratio of 2:1 between atezo and bevacizumab versus sorafenib. OS and PFS being the primary endpoints, and ORR being the secondary endpoint. So the median OS was 19.2 as compared to 13.4 in sorafenib, and the median PFS was 6.9 versus 4.3, and both were statistically significant. So we can see that whereas TKIs were giving a PS median OS in the range of 12 to 13 months, this raised the bar to 19.2 months, which was a significant improvement over the previous standard practice, which was a TKI. So the combination of atezolizumab and bevacizumab certainly gives us a significant improvement in a disease which was otherwise the prognosis was very bad. So 18 months OS, we can see half of the patients survived for 18 months. What is to be noted is that the benefit was, when we do a subset analysis, the benefit in non-viral HCC was not statistically significant. It was in viral etiology HCC, the benefit was there very much, but in non-viral HCC, somehow the benefit was not significant over sorafenib. As far as side effects were concerned, the TKI side effects were less, but the side effects associated with bevacizumab in the form of hypertension, proteinuria were there. And if you can see that grade 3 side effects, the most common one was hypertension, followed by proteinuria and deranged LFT. Fortunately, immune-related side effects were not very common. Whereas we compare to sorafenib, it is overall better tolerated. Now the concept of dual immune checkpoint inhibition in HCC. This is the latest. Atezo and Bev has been the standard for quite a while now. And now the standard has been, another option that we have is essentially a single dose of immunotherapy along with durvalumab, then continuation of durvalumab. So this is a concept that we are all familiar with. We have used in CA lung, we have used in RCC and other malignancies, colon cancer also. So there's definitely biological rationale to this. Blocking CTLA4 as well as PDL1 and PD1 simultaneously, there definitely gives enhanced synergistic anti-tumor activity. It has biological plausibility as well as evidence, scientific evidence for this to this effect. So this is what essentially is being done. CTLA4 inhibits the interaction of T cell and tumor cell, so antigen-presenting cell. It inhibits T cell activation. If we block that inhibition with tremelimumab, it allows T cell activation. Similarly, PD1, PDL1 inhibition, the interaction leads to decrease in T cell activation and leads to ultimately T cell exhaustion. And this mechanism of immune evasion can be reversed if we block this interaction and we give anti-PD1 antibody in the form of durvalumab. So we are quite familiar with the biology of it. What has been interesting noted in the usage of nivo-EP and durvalumab and tremelimumab is that with the first dose of CTLA inhibition, there was a recruitment of T cell. There was spike in the recruitment of T cell. So we can see in Durva-Trem and as well as nivo-EP that there was a spike in the recruitment of T cells. So from this particular phenomenon came the idea that can we just lower the dose of tremelimumab to single dose and recruit all the T cells that we want, and then inhibit PD1, PDL1 interaction by durvalumab and have the effect. So this particular biological idea that was exploited and tested with this study, in which patients of HCC in second line were given tremelimumab and durvalumab, with tremelimumab being given in multiple doses, durvalumab alone Tremi alone, and a combination of durvalumab and tremelimumab, with tremelimab given only in a single dose, that is 300 milligram, followed by durvalumab maintenance. That was known as the STRIDE regimen. So what we saw that among all the regimens, the STRIDE regimen was the one, the T300 plus D regimen, where Tremi was given only for a single dose. There, that was the regimen that showed the highest OS. So the longest median OS, it showed the survival was higher, and there were no new safety signals as expected because we were giving at a lower intensity. We were only giving essentially one drug. So with this came the Himalaya trial, the phase 3 randomized multicenter study of Tremi plus Durva as first line in patients with unresected HCC. So this had randomized into 4 arms, with STRIDE in arm A. Arm B was Durva single, arm C was sorafenib, and recruitment for arm D was not done because of the results of previous study. So this was what it was designed. So it was essentially Durva versus Durva plus Tremi single dose and sorafenib. It was pretty well matched. All the stratifications, all the subsets were pretty well matched in patients. So the basic population was pretty well matched in the 3 arms. And subsequent therapy that was received were also pretty well. And as expected, sorafenib arm patients received immunotherapy in some form later in the lines. So this study demonstrated that the regimen, Tremi single dose followed by Durva, demonstrated a statistically significant improvement in median OS versus sorafenib. The median OS was 16.4 months as compared to sorafenib, 13.8 months. So we can see that the median OS is in the range of Atezo plus Bev. And here we can we can avoid the toxicity of Bev, and even essentially only a single dose of Tremi. So we are giving a single dose Durva for a longer period, and we are able to achieve OS in the lines of a dual agent. Again, as we pointed out in the previous section, Atezo plus Bev, the non-viral etiology, which happens to be the more common one in India now, there was no statistical significance, whereas in T300 plus D, the
Sir,
STRIDE
sorry
regimen.
to interrupt. Kindly conclude in 2 minutes, please.
Who is this?
Abhimanyu Desai, sir. Request you
I'm
to
in the,
kindly conclude your session, please.
I'll do in a couple of minutes.
Sure, sir. Sure. Take your time. 2 minutes, please.
So the non-viral etiology. Okay, so this was done, and it showed benefit in the non-viral etiology as opposed to Durva plus as opposed to Atezo plus Bev, where the benefit was not statistically significant in non-viral etiology. Response rate was much higher with this regimen as compared to sorafenib, and median duration of response was also higher. In fact, 12 patients had CR as compared to no patients having CR in sorafenib. As far as side effects goes, grade 3-4 side effects were seen in 25% patients, and it was less than that seen in sorafenib. In fact, all the adverse effects were less in STRIDE regimen as compared to sorafenib. So tolerance was definitely better than, again, Atezo plus Bev, tolerance was comparable to sorafenib. Here, tolerance is actually better than sorafenib. Yes, so grade 3, some of the patients had grade 3 or 4 diarrhea, but apart from that, grade 3 and 4 adverse effects were pretty less. The incidence was pretty less. Hemorrhage, if we see, why is this important? Because when we give Atezo plus Bev to patients of HCC, most of them, a lot of them have cirrhosis and might have portal hypertension leading to esophageal varices. So the incidence of varicose hemorrhage was 0 in patients of this regimen. Again, a point it scores over Atezo plus Bev combination. NCCN now mentions Tremi plus Durva as a preferred regimen category 1 along with Atezo plus Bev. And single agent Durva is also a recommended regimen, but it's not the preferred. The preferred, what we have now is Atezo plus Bev or Tremi plus Durva. So HCC is one of the important cancers that is affecting Indians with a high mortality rate. Immunotherapy combinations have now shown that they have better anti-tumor activity than TKIs alone. Atezo plus Bev has been the new standard of care in advanced HCC. The STRIDE regimen, that is single agent Tremi plus Durvalumab, improved OS versus sorafenib and demonstrated an unprecedented 3 years OS rate, which was 40%. So STRIDE seems to be benefit from all subgroups, including non-viral etiology, and STRIDE was well tolerated with low rates of discontinuation and GI hemorrhage. So this now potentially is a new standard of care along with Atezo and Durva. Thank you so much, organizers, for giving the opportunity. I hand over the dice to the organizers now.
Thank you, sir, for sharing your insights and valuable perspectives on this particular answer, in which multiple options are there, but we need to have a individualization for the plan for the patient. Moving ahead, I would like to invite Dr. Manish Jain. Sir is a senior medical oncologist at Ruby Hall Clinic. Sir, I would like to invite to share his thoughts with us on the role of TDXT in HER2 low positive cancers. Sir, over to you, sir.
Thank you. Can I get my slides, please? Good evening, everybody. Basically, I'll be discussing HER2, that is trastuzumab deruxtecan, in treatment of HER2 low, that is IHC 1 plus and 2 plus FISH negative metastatic CA breast. Next slide. Can we get the slides? Yeah, we can go to the next. Okay, skip this. Okay, breast cancer is the most common form of cancer worldwide. The global estimated standardized breast cancer incidence can be seen in the picture. The overall 5-year survival for an MBC is 25%, and MBC, as we know, remains incurable. Next slide. MBC was classified earlier as IHC 0 and 1 as negative, 2 plus had FISH positive and negative. FISH negative were considered HER2 negative, and FISH positive were in HER2 positive. So this was the previous classification, and it was determined by IHC and FISH. Next slide. We also know that patients who were hormone positive were treated on first line either by endocrine therapy, CDK4/6, or endocrine monotherapy or chemotherapy, average 28 months survival. Second line were mTOR or an endocrine with PIK3 or a CDK4/6, and an average was 16 months. And the third line was an endocrine PIK3 or endocrine mTOR or chemotherapy, and the average was 6 months. And the HER2 uh, hormone negative, HER2 negative were even worse. So they had like 8 months in first line, 6 months in second line, including immunotherapy and ADCs. And the third line was just 2 months. So this was a very poor outcome of HER2 negative patients. Next slide. But with Destiny Breast 04 establishes that HER2 low MBCs, like if you have IHC 1 plus or 2 plus and FISH negative, then these are called HER2 low, and they comprise of a significant number, 50% of all MBCs. And this has become an actionable mutation in HER2 low expression. So this is something now we need to understand to classify HER2 low disease as a subset, and HER2 plus and HER2 zero. So these are the criterias of separating them out, because you have a better drug now. Next slide. So Destiny 4, as we know, this is the area where you can use the drug as a targetable population in second line metastatic breast setting. And HER2 is also approved for second line HER2 positive MBCs if they have used up their trastuzumab, pertuzumab in first line setting. Next slide. So almost 50% of MBCs may be classified as HER2 low, and they may benefit from UNHER2. Next slide. So now if you look at NCCN guidelines, it recommends UNHER2 as a category 1 preferred systemic therapy for recurrent, unresectable, loco-regional or stage 4 HER2 negative for patients who have IHC 1 plus or 2 plus, and it is given as 5.4 milligram per kg IV every 21 days. Next slide. So let's understand what is UNHER2 monoclonal antibody. Next slide. UNHER2 is a specifically engineered HER2 directed antibody conjugate. It has potent topoisomerase inhibitor payload that is 10 times more active than the irinotecan. It offers different cytotoxic class than the other anti-HER2, which is helping like prior taxanes, microtubule inhibitor. So even if you have failed this, like taxanes, vincalcaloids, eribulin, you still can use this drug. And there is a membrane permeability to this drug. So it diffuses across the cellular membrane and kills the adjacent cells. Now that is the beauty of this drug. So it has a bystander effect. Also, there is a tumor selective cleavable linker. Now that is very stable in plasma, and it gets cleaved only by the enzymes upregulated in the tumor cells, which leads to a very targeted localized release of cytotoxic payload. So this is an HER2 directed antibody drug conjugate. Next slide. So the attributes of this drug are, it is directed, next slide, it is directed against HER2. It has an antibody trastuzumab. It has a payload exatecan derivative and topoisomerase inhibitor monoclonal antibody. Drug to antibody ratio is 8:1 and a selective tumor linkage. And we also know there is a bystander effect. So these are the qualities of this drug. Next slide. So if you look at this picture, it tells you that UNHER2 binds to HER2. Next, then it gets internalized. Next, can we have the next? Yeah, so it binds there. Next, it gets internalized. Next, then the linker cleaved releases topoisomerase inhibitor. Next, then it enters the topoisomerase 1 inhibitor, enters the nucleus. There is a tumor cell death, and then you see a membrane permeability. Payload releases the bystander effect, and the cell adjoining cells also die. So normally what we knew that HER2 positive, we need to have very strong positivity to create an effect with trastuzumab, pertuzumab, or even Kadcyla. But here you're getting a bystander effect. So even with a low HER2, the drug is effective, and that's the reason of the drug being effective. Next slide. Next. So Destiny Breast 04 study design. Basically, it's a phase 3 open label multicenter study. Patients were either 1 plus or 2 plus IHC, fish negative, unresectable, metastatic, had to undergo like 1 or 2 chemotherapy in metastatic setting. If they were hormone positive, they should have been considered as endocrine refractory. So 1 or 2 lines of failure, and this they should have received chemotherapy in a metastatic setting. So they were randomized as 2:1. And here we see that hormone positive were 494 and hormone negative were 63. This is reflective of real world prevalence. So this is how the patients were either randomized to UNHER2, or they were given either a choice of capecitabine, erbilin, gemcitabine, nab-paclitaxel, depending upon what was the investigator choice. Next slide. The demographics were well balanced in hormone positive and all patients. You see that the patients were very well balanced in terms of HER2 status, ECOG, or hormone positivity, negativity. Next slide. And they were also well balanced in terms of, their brain mets, lung mets, or liver mets. Next slide. The prior lines of treatment in all patients as well as hormone positive patients. Next slide. Can we have? Next. So the systemic lines of treatment in metastatic setting or chemotherapy in metastatic setting, lines of endocrine therapy, prior targeted therapies, they're all well balanced. Next slide. So let's look at the efficacy data. Next slide. Anher-2 nearly doubled the median progression-free survival and extended uh, median OS by 6 months versus chemotherapy in hormone-positive HER2 low MBC. The PFS increased from 4.7 to 10.1, and the hazard ratio was 0.51, and p-value was quite significant. And in OS, you look at it went from 6.4 months to 23.9 months, hazard ratio of 0.64. Sorry, the chemotherapy median OS was 17.5 versus 23.9, an advantage of 6.4 months. Next slide. And this is consistent in all patients. If you look at, again, you get an advantage of p-value being very significant in progression-free survival, and OS also getting improved by 6.6 months in all patients, that is including HER negative, hormone negative are patients also included in this group. Next slide. So this is the forest plot showing that it is favoring Anher-2 in all the parameters, and you can see a significant shift. Next slide. Anher-2 tripled the overall response rate compared to chemotherapy in both hormone positive as well as in hormone negative patients. And there was a significant advantage, almost going from 16.3 to 52 and 16.7 to 50. So this was quite significant. Next slide. Now, if you look at the waterfall plot, you can very well see that almost every patient responded to Anher-2, and a very quick and a very steady response you can see compared to the chemotherapy arm. Next slide. So exploratory subgroup analysis shows that consistent Anher-2 efficacy in all patients of hormone negative HER2 low MBCs. So this is like the progression-free survival what we saw, Anher-2 8.5 months versus 2.9 in chemotherapy arm, median survival 18.2 versus 8.3, and overall response rate 50 versus 16.7. So duration of response was 8.6 versus 4.9 months. Next slide. So let's look at the safety data of Destiny. These were the common side effects. See, there are side effects of the drug. So you have nausea, fatigue, vomiting, neutropenia, anemia, uh, sometimes leukopenia, diarrhea, constipation. So diarrhea, constipation is around 20%. And you can see that it is pretty well tolerated, but yes, there are certain side effects linked to this drug. Dose modification to manage the adverse reactions. There was around 23% dose reduction compared to chemotherapy in Anher-2 arm, and dose interruptions were 39% compared to chemotherapy. Discontinuation was 16% versus chemotherapy 8%. And the major side effects were nausea and fatigue. In chemotherapy was neutropenia, and the most common discontinuation reason was Anher-2 was ILD or pneumonitis, and in chemotherapy it was peripheral neuropathy. So we should be very careful when we are treating with Anher-2 regarding ILD. We will discuss this, how to handle this. Next slide. So ILD pneumonitis with grade 5 cases were reported in Anher-2 Destiny, and most of the cases were like grade 1 and 2. Grade 3 pneumonitis occurred in 2.2% patients, that is 8 patients out of 371, and this was consistent across all the thing. The median time to get ILD was around 129 days. Next slide. The quality of life data. Next slide. You see that it was almost flat for both chemotherapy as well as Anher-2. There was not much of, they were maintained all throughout. Next slide. Dosing and administration. We all know that for breast cancer, we have to give 5.4 milligram per kg every 3 weeks, and it has to be initially administered over 90 minutes, and subsequently you can reduce it down to 30 minutes. And if you miss out on the planned dose, you need not wait for the next cycle. You can start it off as soon as the patient recovers, and you can go ahead and give the subsequent dose 3 weekly. There can be an interruption done if there is an infusion related reaction. And if there is a severe infusion reaction, you have to permanently discontinue the drug. Otherwise, you can continue. Next slide. Regarding dose modifications, you start with 5.4 milligram. If there is a first dose reduction to 4.4, you don't go back to the original dose. You can continue on the same dose. If there is a second dose reduction, it should be 3.5 mg per kg. Beyond that, if there is a dose reduction required, you have to stop the drug. Next slide. For dose modifications regarding specific adverse reactions, if there is an ILD, if it is grade 1, within 28 days it resolves, you can restart at the same dose. If it is grade 2 or more, you need to permanently discontinue on HER2. Always make sure that you monitor these patients 8 to 12 weeks for and ask the patient if they have cough, breathing difficulty, or watch out for their saturations each cycle. So this is a very important aspect of this drug. The second part is neutropenia. Most of the patients will get a grade 3. Up to that, you can do not have to, you have to interrupt and restart at the same dose. But if there is a grade 4 neutropenia that is there, less than 500 counts, you need to reduce by one level. Febrile neutropenia, interrupt on HER2 and reduce by one level. Thrombocytopenia, if it is grade 1, don't have to worry. But if it is grade up to grade 3, just resolve, restart. If it is grade 4, you have to reduce by one level. Next slide. Left ventricular dysfunction. If it is symptomatic congestive heart failure, permanently discontinue. If it is LVF less than 40% and more than 20% from baseline, you need to repeat. If it is not recovering, permanently discontinue. Otherwise, you need to just interrupt, let them recover, and you can restart the drug. So LVF is not so difficult in this particular thing, what we have seen for other trastuzumab containing regimens. Next slide. For AE management, nausea and vomiting, you need to use standard antiemetics as we use olanzapine. You can use aprepitant, 5-HT3 blocker, and dexamethasone, and they need to be started before starting the drug. So you can use this as a standard regimen based on your practice. So you can use one of these NCCN guidelines. Next slide. Basically, make sure that you give olanzapine, aprepitant, dexamethasone in case you are planning that on day 2, 3, 4. Next slide. So if there is an ILD, we already discussed that, if it is grade 1, you start steroids early and make sure that you continue it up to it resolves. You may go ahead and taper it as we do routinely. You may give it like 0.5 mg per kg prednisolone and taper it over 4 weeks. And you need to delay the treatment during this period unless they recover fully. Next slide. So an expert opinion paper, this is recommending ILD, how to manage. Basically, you may use steroids. That is what is required. Second is antibiotics, and Septran can be used because you're going to use high dose steroids. So you need to monitor the patient, hospitalize, oxygen therapy, and SOS potential ventilation is also required in certain cases if they're severely breathless. Next slide. So the treatment is simple. If it is grade 1, just give steroid. Next slide. And if it is grade 2, increase the dose of steroid to maybe 1 milligram per kg. And then you taper it over 14 days. Next slide. Can we get the next slide? Yeah. So this is what is for grade 2. Next slide. And monitor through lung examination, respiratory function, oxygen saturation, and CT scan, HRCT, basically to look at ILD. Next slide. If there is any symptoms, do an HRCT. Regular assessment of patient is a key for early identification. and I explain the patient that if you have got cough, breathlessness, anything, fatigue, like climbing, while climbing, you find exercise tolerance difficulty, you need to inform. Next slide. So this is a case of 49-year-old female with strong family history. February 21 was diagnosed as TNBC. She was ERPR negative, HER2 2 plus, because in those days HER2 2 plus fish negative were considered as HER2 negative. So, and BRCA positive germline mutation, patient received standard AC followed by T and then MRM and axillary lymph node dissection. She was a 49-year female, mother of two, grandmother of one, and her mother had died of ovarian cancer at age of 62, perimenopausal, ECOG 0. Next slide. So there was a first progression very soon. So February she got treated. October she developed pain in the chest and axillary region, and there was swelling in the area. PET scan had shown recurrence in subpectoral region, what we see on the PET scan here, and in the bones. So a biopsy was done. Next slide. So biopsy showed that it was ERPR negative, HER2 2 plus, fish negative. PDL, next slide. PDL1 CPS score was more than 90. So she received palliative radiation to subpectoral for her pain, and she was started on pembrolizumab and gemcarbo. After 4 cycles, next slide, she could not tolerate the chemotherapy. So only single agent pembrolizumab was continued. And in January 23, she had progression of disease. And this time the biopsy was ERPR negative, HER2 negative again. Next slide. So second line, olaparib was started, and olaparib she continued up to 5 months, and then she had again progression in May 23. So the patient had failed pembrolizumab, olaparib, and the standard chemotherapy earlier. So for the third line, June 23, she was started on Anhartu, and September, the first scan showed almost a CR, and December 23, the patient was continuing on HER2 as per the last scan. So this is an case which is very interesting. When we had no treatment available, there was a significant response seen in a patient. This is Anhartu is the first and only HER2 directed therapy to provide significant survival advantage to patients with HER2 low, that is IHC 1 plus or 2 plus, MBCs after progression on standard therapies. And it is almost doubling the median progression-free survival, increasing 6 months of median OS. There is a 3 times increased overall response rate. Next slide. So this is about the drug. Basically, there are the only difference is in Anhartu we use 5.4 mg per kg in breast, and we use 6.4 mg in gastric cancer. So that's the only difference you can know from this. I think that's the end of it. If there are any questions, we can take it.
So there seems to be no question. You have already covered the topic in such detail. Thank you, sir, for sharing your valuable insights on this topic, which is the drug is slowly revolutionizing the treatment of HER2 positive and HER2 low cancers in various organs. Without taking much time, I would like to invite Dr. Pinaki Mehto, sir, from HCG Vadodara, to moderate the session on HER2 positive carcinoma breast. Over to you, sir.
Am I audible and visible?
Yes, sir.
Let me share my screen. Is my screen visible? Is my screen visible?
Yes, sir, it's visible, sir.
Okay, so I think we have got approximately 15 minutes. It's now almost 8:15, so I'll try to finish by 8:20, 8:30, 8:35. So thank you organizers for having me. The topic that I've been given is basically HER2 positive. I will be confining myself to discussion about HER2 positive early breast cancer, because discussing the total HER2 positive breast cancer would be very difficult. I would like to invite my panelists. I hope all of them are there. I'll just start. These are the disclaimers. So this is the case history. This is something what we commonly encounter in our day-to-day practice. A 45-year-old lady who is premenopausal has presented with a growing mass in the left breast that was noticed 2 months back. And now the mass has now increased in size and has become painful to touch. There is no relevant previous history. On physical examination, she has a 3 centimeter mildly tender mass in the left breast with no underlying skin changes or nipple discharge. There is a firm enlarged axillary lymph node also palpable in the left axilla. The rest of her examination is within normal. So I think first of all, I would like to invite Dr. Bhavna ma'am if she's there. As a surgeon, how would you go about in this kind of clinical scenario?
Hello.
Yes, ma'am, you're audible.
Yeah. What is your question?
Ma'am, there is a 45-year-old lady who is premenopausal who has got a 3 centimeter lump in the left breast as well as
Okay.
a palpable axillary lymph node.
Okay, I'll go for the two-cut biopsy. The biopsy has not been done, and of course, histopathology, ERP, HER2 KI67,
Yeah.
and US regarded FNSC of axilla to prove whether it is pathologically positive.
Okay.
This is what my routine workup, and of course, the metastatic workup in terms of either I'll go for the whole body CT scan, contrast CT scan with bone scan, or else PET CT scan. Because the palpable nodes are there. At least CT chest and upper abdomen contrast. At least I want to do with that. Since I mean, otherwise it is upper outer quadrant mass.
Yeah. Ma'am, so in this kind of situation, if you find that the disease is localized to the breast and there is axillary lymph node and it's a T2N1 kind of disease where you have a single lymph node that is positive and you have a 3 centimeter primary lesion in the peripheral breast, would you go for primary surgery or would you still like to see the biology and then decide whether you want to go for
No,
neoadjuvant?
I love to go for biopsy just to for the TNBC and HER2 positive patients because in T2 2 centimeter plus with N plus we generally go for neoadjuvant therapy in TNBC also and HER2 positive also. If this would have been ERPR strongly positive, HER2 negative, I would have still gone for the thought of doing a surgery for, but not today at least, not in at least this January 25. I will definitely go for the IS system.
Yeah. So looking at the biology, you will decide whether to send these patients or not for neoadjuvant therapy vis-a-vis going for a primary surgery.
Yes,
So I
yes,
think,
yes.
yes, ma'am. Thank you. So I think, Dr. Priyanka, are you there in the panel? Okay. Dr. Jimmy, are you there?
Yes, Dr. Priyank.
Yeah. So, Dr. Jimmy, how do you define patients with high risk, especially when you're talking about early breast cancer? How do you define patients who are at higher risk, and what would you do separately for them, and what will you do differently about these patients?
So in the patients who have the early breast cancer, the disease biology is the main factor to consider for the further treatment and new agent to be given or not. So as well as we consider the family history as well as, and we should also consider the age of the patient also into the considerations. And if the every factor is the on the favorable side, that hormone positive biology or HER2 negative disease, hormone positive disease, then we should consider surgery first. And otherwise, in this all other scenarios where the nodal disease is on the higher side or the strong genetic history, triple negative breast disease, then we should consider the chemo, neoadjuvant chemo first. And if HER2 positive disease, T2N1, definitely we should try neoadjuvant chemotherapy along with the anti-HER2 therapy. That will be the best results.
Thank you, Dr. Jimmy. So, because we are talking about an early HER2 positive breast cancer, so let's say this patient was having a ERPR negative status and a HER2 positive status. So, Dr. Siddharth, are you there? Dr. Siddharth?
Hello, yeah, yes, sir, I'm there.
Yeah. So Dr. Siddharth, in this kind of patient who is a premenopausal, has a node positive left breast cancer, if the patient is HER2 positive, do you go for genetic testing or you will not go for genetic testing in this kind of patient?
So usually, sorry, there is some disturbance.
Yeah.
So
So my
usually
question,
we,
yeah. Please.
sir, I'm sorry, there is some disturbance. Uh, Usually we do not go for genetic testing in such patients. In cases where we have a family history is positive or the patient is triple negative or means younger patients we usually go for genetic testing in such cases, but otherwise, routinely we do not go for genetic testing.
This
The
is a
patient,
45-year-old lady, so yeah.
sir, we are trying to make a practice to go for genetic testing universally, but uh, this could be plus minus, means yes, I would like to go for genetic testing.
Okay. Okay. Akash bhai, are you there?
Yes, I'm there.
Akash bhai, what is your practice? A young patient who comes to you with a, let's say, ERPR positive and a HER2 positive disease, would you routinely go for genetic testing, or you would individualize your patients only if they have a family history, then you will go for genetic testing?
In HER2, if there is family history or too young, means less than 40 years or 35, then only I go. Otherwise, in HER2, I don't go. And as per experience in HER2, I have not seen any patient till now I have sent if anybody is positive, even if there was a strong positive family history.
Okay. So I think great experience sharing from Akash sir's side that he has not seen any patients. So the incidence actually is very low. With HER2 positive, you might get BRCA, but it's very, very rare. Dr. Dipen, are you there? Okay. So a mammography was done, and there was a 4 centimeter lesion in the left breast. Also, there was ipsilateral enlarged axillary node. The biopsy suggested that it was a grade 3 kind of IDC, and it was ER was 50%, PR was 0, and HER2 was 3 plus by IHC. And the axillary lymph node was also positive for adenocarcinoma. So it was a T2N1 HER2 positive, hormone receptor positive breast cancer. Again, Dr. Bhavna ma'am, do you routinely clip the breast as well as the axilla in such patients?
I routinely keep the breast tumor after 2 to 3 cycles of chemotherapy.
Yeah.
Of course, I examine patient every cycle, and if the patient is taking chemotherapy somewhere else, I make sure that I'll see patient after every second cycle. Before it gets disappear, we generally put clips. It is radiology guided clip. I'm not practicing till post NACT, SLNB, but yes, in like targeted axillary lymph node dissection and all, you must keep axillary lymph node.
Yeah, so I think more data is needed before we routinely started doing targeted axillary dissection. But I think some centers are now trying to do it. So if they come up with their individual data, probably will understand how to go about it. So I think
It's not about the data. Data is already valid, and post NACT, SLNB, and I mean target axillary lymph node dissection is already proved. But the
Okay.
issue is that the clipping and marking the axillary lymph node is not very technically easy. Some people are now trying for the Indian ink and all that things also. But I've not practiced. Probably will practice. So I'm not worried about data, but it is not. I have not validated my own.
So one can not probably one might not clip the node, but look at the post op after neoadjuvant, you look at the radiology, and then you decide to go for an SLNB.
If you don't want to do target axillary lymph node dissection, if you want to just go for the sentinel lymph node biopsy, even if you have not clipped the axilla, if some patient, you might have seen the patient after first or second cycle of chemotherapy, patient came consulting somewhere else, then also you can go for the sentinel node biopsy post NSA. If it becomes n plus 2, n 1 plus 2, n0, then only you can go for the post NACT SLB.
Okay. So we know these are the numerous advantages of neoadjuvant chemotherapy, and as ma'am already said, a T2N1 would be happily sent by the oncosurgeon to take neoadjuvant, especially if the patient is a HER2 positive breast cancer. These are the numerous advantages that you can. The most important advantage is probably when you get an understanding of the biology, how the response happens, and depending upon the biology, we can again stratify these patients and escalate or de-escalate their subsequent treatment. These are guidelines. I think these are the AGO guidelines which were updated 2022, which basically say that either anthracycline or a taxane-based chemotherapy has to be included along with HER2 positive targeted therapy when we are going for the neoadjuvant therapy. Again, these are something that has been discussed numerous times, so I'm not going in detail, but for probably this is again an interesting question that which are patients who would not receive any systemic therapy. So Dr. Siddharth, you can take this question. Any HER2 positive early breast cancer where you would not give any anti-HER2 therapy. Let's say you only give hormone therapy to these patients. You can unmute,
Yeah. Sir, Basically, in patients who have a tumor which is less than 1 centimeter in size, and we can go for upfront surgery, then in such cases we would probably not go, and if they achieve pathological CR, in such cases we may not need to go for any systemic therapy, or maybe only endocrine therapy can work. In other cases, more than 1 centimeter, I would definitely prefer to go for systemic therapy in most of the cases. But doing such things in practice is practically very rare. Means we would usually go for systemic therapy to avoid any risk of future recurrence, things like that. But less
Yeah,
than
so
one
I think
centimeter, that is one subset.
less than 1 centimeter should be the guideline where we probably can avoid this, because whatever data we have, it is not, the quality of evidence is not that great, and there are very conflicting data. So generally, if it is less than 1 centimeter, probably even anti-HER2 therapy can be omitted. For disease that is between 1 to 2 centimeter, I think we have excellent data now, 10-year follow-up of the APT trial, which shows that there were very, very few events. Even at 10 years, there are very few events that have happened both in the local as well as the distant recurrence. So I think this is something that all of us have accepted, and now we are using, especially for the T1C disease. Also, there is an option to give TDM1 as a single agent, but there are some toxicities, though this also has excellent 5-year data. And now there is a trial that is again going on, where you are just giving the dual HER2 plus hormone therapy in the stage 1 disease. Let's see how this data comes and whether we can avoid chemotherapy in this subset of patients. Now we know that dual HER2 has transformed the standard of care, whether it be early breast cancer or in the adjuvant setting or in the metastatic setting. And this has been recognized by all the regulatory bodies. We have discussed the clinical trials in this setting time and again. Is anthracycline necessary? So again, Akash bhai, do you feel any need for giving anthracycline in early breast cancer, which is HER2 positive?
No, no need. I
No
don't
need.
give.
Yeah. Is Priyanka there? No. Dr. Jimmy, do you give anthracycline any of your patients?
No, most of the patients we go for the Texan-based regimen, Texan with antibiotic.
Okay. Okay. So Dr. Dipen is there or not? No. So I think we have got clear-cut data from the BCIRG 006 as well as from the TRAIN2, which tells that probably giving neoadjuvant anthracycline does not add much to the efficacy, but adds to the toxicity. So most of us now probably are quite comfortable omitting anthracycline in this subset of patients. We saw that the DFS and the OS even in the Trifina trial did not change whether you gave anthracycline or not. Currently, what we generally do is something what was done in the Christine trial, where you give TCHP for 6 cycles. The PCR rate is somewhere. If you There are different definitions of PCR, and based on the ERPR ERPR status, you might have different PCRs, but it is somewhere between 50 to 70% is what has been quoted in the trials. And in my day-to-day practice, we have a lower rate of PCR that is somewhere around 30%. But this is something that most of us have now become comfortable using. If you look at the analysis of the neoadjuvant trials, going for a dual HER2 in the neoadjuvant setting, followed by a dual HER2 in the adjuvant setting, probably is associated with the maximum EFS. But the difference in the OS is still not clear, and definitely we need more follow-up data that tells us that we should be using dual HER2 both in the neoadjuvant as well as in the adjuvant setting. Definitely there are lesser events, but it is still a difference in the EFS and not in the OS. So probably more follow-up will understand whether there is a survival advantage of continuing this dual HER2 in the subsequent setting as well. And there are studies like Berenice and PNO, which basically showed that there is a higher DFS if you give neoadjuvant dual HER2 in the neoadjuvant as well as in the adjuvant setting. And NCCN also says that we should go for TCHP, that is, and if there is no residual disease, we can complete 1 year of HER2 targeted therapy. They have not specified it is trastuzumab plus minus pertuzumab, because the trials were not clear in this regard as to what to do. This is a very interesting trial, and this is something that I think has come up for again, where basically you give 2 cycles of dual HER2 therapy plus minus hormone therapy. If you get a very good response, you can go for a PET assessed response, and if you get a very good response, you probably don't give chemotherapy. And here they showed that almost 38% patients had a PCR despite not receiving chemotherapy. So a significant one-third of patients probably can avoid chemotherapy even in HER2 positive breast cancer is what was shown, and definitely the patients are mostly stage 2 and stage 3, and almost half of these patients are node positive. So, Akash bhai, what is your take on this trial, Fergin trial? Can we consider such kind of practice in our patients as well?
Yes. Yes, I think I'm having some positive vibe for such this trial, and at least one third patient we can avoid chemotherapy.
Yeah. So So I think this is a very interesting and very nicely done trial where you use two endpoints. One is PET scan and one is PCR, and you have got very good 3-year data. So let us follow it up and see where it leads us. But the IDFS at 3 years is 96%, which is, I think, excellent. Now, talking about adjuvant therapy affinity, it's a controversial trial. If you look at the OS benefit, there is no OS benefit. It's less than 1% OS benefit if you look at the overall population. However, they try to dissect out patients who are node positive. There is a DFS advantage of something around 5% at 8 years, which is not a OS benefit. So again, looking at this, is it a practice-changing trial? Still, I think it is debatable. Dr. Siddharth, would you, given a chance, always go for adjuvant pertuzumab if cost is not a constraint, or you believe that DFS is equal to OS at 8 years?
For sure, DFS is not equal to OS, but the patients, node positive patients are high risk patients, and they have been shown to have good DFS advantage. In all of my patients, I try to give pertuzumab, and especially since now cost is not much of a constant with many of the PAPs available, and the different means PAP is freely available, and it is much more affordable now. So I give it to almost all patients.
So you would give pertuzumab. Dr. Jimmy, what is your belief? Is DFS equal to OS at 8 years, or you will get some OS difference at even after this?
No, I think if node positive disease, they have subsetted the data. But if the patient is affording, then I will go for the pertuzumab addition. Otherwise, trastuzumab, I think, with a good PCR.
So 17 cycles of pertuzumab is 18 cycles of pertuzumab is quite expensive. So
Quite expensive.
still OS is not there, but DFS is there in node positive. So in that subset of patients, you would be interested. Whereas Catherine, you have got OS advantage. So there is no doubt about Catherine that you should give, because it's an OS advantage of almost 5% at 8 years. The only problem with Catherine is there is a subset of almost 15% patients who even in spite of receiving TDM1 had brain mets. And so that is one subset of patients which worries us, because we know that HER2 positive is more prone for brain mets, and this subset of patients actually did not benefit by giving the TDM1 adjuvant. So probably TDXD probably might be better in this subset, but obviously we need to see. There is a trial going on, the Destiny Breast 5, which is comparing the adjuvant TDM1 versus TDXD. So it's interesting to see what happens in this trial. There are biomarkers now coming up. There is a very interesting biomarker called HER2-DX, which has been recently brought out. And this biomarker actually has different parameters. One parameter is to look for patients who are having a higher probability of getting a PCR, as well as there is a parameter which tells us what is the probability of survival. So it has been seen that the genes that are involved in getting a PCR are not the same genes that are associated with better survival. So all around we are saying that patients who get a PCR probably have a better survival, but probably this trial shows that the genes associated with the likelihood of a PCR and the genes associated with the likelihood of better survival are slightly different. But again, this is something that is new and going to come up in the future. Obviously, challenges are there in HER2 acquisition when we give intravenously trastuzumab, pertuzumab. The waiting time is more. You need good intravenous access, and you might have complications because of intravenous therapy. And therefore, a subcutaneous trastuzumab, pertuzumab is available since now some many years, and it is very comfortable to us. There were primarily two trials, the Frederica, which basically tried to compare the pharmacokinetics, the C trough and the area under curve, and it was found that both these were almost similar. Only subset of patients where there was a problem was patients who have a BSA that was less than 18.5, or a patients who had a BSA that was more than 30. So in these two subset of patients, probably avoiding subcutaneous version would be better. But otherwise, you can look at it that the C trough levels and the PCR rates were actually quite equivalent when you compare the subcutaneous versus the intravenous one. Also, the adverse events, including the cardiac safety, were not much. The cutaneous adverse events, the local side effects were not more with the subcutaneous dual HER2 blockade. So it was comparable, and I think all of us are quite comfortable using this. Till recently, when we didn't have a generic version, all of us were actually preferring the subcutaneous version as compared to the intravenous version. Francisca was again something similar to this, where you gave both the versions and you asked the patients, and almost 80% agreed that using a subcutaneous version is better than using a intravenous version. So this patient also received neoadjuvant chemotherapy with a subcutaneous dual HER2 blockade with docetaxel and carboplatin, and had some side effects like mucositis in third cycle. It was managed, and finally she got a PCR. So as already discussed, if this patient with a neoadjuvant dual HER2 blockade gets a PCR, Dr. Jimmy and I would discuss whether to give adjuvant pertuzumab or not, but Dr. Siddharth definitely would be very inclined to give adjuvant pertuzumab. So I think the data from affinity we are actually including in this, that whether to give or not. But if the patient did not have had a residual disease, it is very clear that we should go the Catherine way and give the TDM to this patient till we have data from the Destiny Breast 5. So I think again this is something that we have already discussed. So I think this finishes the panel discussion. I think this is again which questions that we have discussed. So thank you all for the patient hearing. I'll just hand it back to the organizers. Thank you.
Thank you, Pinaki sir, for wonderfully moderating and summarizing the role of HER2 positive CA breast. I would like to also thank the panelists for sharing their knowledge and experience on this particular topic. Moving forward, next I would like to invite Dr. Pritesh Manoj sir, who is practicing at Bombay Hospital, Mumbai, to share his thoughts on peri-op immunotherapy in early stage CA lung. Over to you, sir.
Yes. Can I share my screen? Okay. Am I audible, sir? Hello.
Yes, sir. You are
Yeah.
audible and visible as well, sir.
Correct. So, good evening, everyone. My name is Dr. Pritesh Manoj, and we'll be speaking about perioperative immunotherapy. Okay. Yes, perioperative immunotherapy, a new frontier in resectable non-small cell lung cancer. So, yeah. So there are almost 2 million new lung cancer cases annually worldwide, out of which around 85% are non-small cell lung cancer, of which only 30% are resectable at diagnosis, out of which somewhere around only 20% go for resection or a curative surgery. What is important to note is even after resection, the chances of recurrences are very high, as much as almost 50%. As the stage increases, the chance of recurrence increases. For example, for stage 3, the chances of recurrence is almost 76%. So out of 4 patients that you operate, almost 3 recur. So there is a huge unmet need to reduce the disease recurrence and improve survival in resectable non-small cell lung cancer. So we all know that adjuvant cisplatin based is recommended for patients stage 1B to 3A and stage 1B to 3A. It improves overall survival by around 3% to 6-7%. However, the rate of disease recurrence are still very high, irrespective of post-operative chemotherapy use or not use. The concept of using perioperative regimens would further improve long-term outcomes by combining the benefits of neoadjuvant and adjuvant therapy to prime for anti-tumor immunity, to treat micromets and lymph nodes if present. So neoadjuvant and adjuvant immunotherapy have shown promising results with acceptable safety profile. Neoadjuvant immunotherapy have several advantages like more robust and durable anti-tumor response. It prevents immune tolerance and escape mechanism. Combining neoadjuvant immuno with chemo followed by adjuvant immuno is expected to improve activity and long-term outcomes in patients with resectable lung cancer, and the chance to treat frail or immunosuppressed patients who post-surgery are not very fit for any form of therapy. NCCN guidelines recommend neoadjuvant immuno plus chemo or adjuvant immuno plus or minus chemo post-surgery. So these are the phase 3 trials that have been published. Checkmate 816, which is chemo plus immuno for 3 cycles, followed by surgery, which showed improved EFS with PATH-CR, and even the update is relatively very good. IMpower 10 showed surgery followed by adjuvant chemo followed by atezolizumab for 1 year, which showed improved disease-free survival. Keynote 091 was chemo followed by pembrolizumab in adjuvant setting. Agent trial, which is a new approval for durvalumab, which shows perioperative chemo plus durva, followed by surgery, followed by durvalumab for 1 year. Neotorch trial, which shows peri-op chemo plus toripalimab, and Keynote 671, peri-op chemo plus pembrolizumab. These are the trials which have shown some amount of event-free survival or disease-free survival, and these are the phase 3 trials that are published. So, as I said, neoadjuvant checkmate 816 is there, in which only neoadjuvant therapy is given, no adjuvant is advised. This is FDA and EMA approved both. Adjuvant trials, there are two: IM Power 010, which is for atezolizumab, and Keynote 091 for pembro. Neoadjuvant followed by surgery, followed by adjuvant, that's peri-op. The latest is AGN trial, Keynote 671, Checkmate 77T trial. So we'll be discussing AGN trial in detail. The reason that this trial is interesting is all the trials that were mentioned previously, among these, all these trials had patients stage 1B to 3A or stage 2 to 3A. This is the only trial which included stage 3B, that is N2 disease also, and they had taken stage 2A onwards patient. So if you look at the study population, all treatment naive, ECOG PS 0 or 1, resectable stage 2 to 3B patients were included who had resectable disease on presentation with wild type EGFR ALK status, obviously. They were randomized 1:1 into durvalumab plus chemo, followed by surgery, followed by durvalumab for 1 year, or placebo plus chemo, followed by surgery, followed by placebo for 1 year. The primary endpoints were pathological CR and event-free survival. Key secondary endpoints were pathological response, disease-free survival, and overall survival. The study question was, does neoadjuvant durva plus chemo followed by adjuvant durva improve path-CR and event-free survival in resectable stage 2 to 3B non-small cell lung cancer compared to neoadjuvant chemo plus placebo? Coming to baseline characteristics and planned treatment, average age was 65. Majority of the patients were male, 70%. ECOG PS 0 or 1. What is more important to see is Asian population was almost 40% in both arms. Stage 3B patients were almost 25% in both arms. Histology, almost equivalent squamous and non-squamous. And cisplatin was used in 27 versus 25%, and carboplatin in almost 2/3 of the patient in both arms was there. Another thing that was important is N2 disease status, which is generally a poor stage or poor outcome disease. Almost 50% in both groups were N2 patients. Coming to updated event-free survival, at 3 years of follow-up, the median EFS was 30 months versus not reached. If you can see at 36 months, 60% patients are doing well as compared to 47% in placebo arm. So there is a good statistically significant EFS benefit. Coming to benefit in across subgroup, it was seen almost in all subgroups there was benefit of placebo versus durva, especially in squamous versus non-squamous. There was no difference. Stage 2, 3A, 3B all had benefit for durva arm. Lymph node status, N2 or N, all lymph node status, all stages had benefit for durvalumab. Coming to which agent was, irrespective of cisplatin or carboplatin was used, there was statistically significant benefit in durva arm as compared to placebo. Coming to pathological response, 17% versus 4% in placebo, which was similar in almost all the trials that we had mentioned previously. Looking at the subgroup, all subgroups, irrespective of PDL1, irrespective of histology, irrespective of stage, all subgroups favored usage of durvalumab as compared to placebo. Coming to toxicity and safety profile, most of the side effects were well tolerable. Most of the side effects were almost similar in placebo versus durvalumab arm. Something to note is pneumonitis was seen in 3.8% of the patient versus 1.8% of patient in placebo arm. More important to understand is most of the pneumonitis was grade 1 and grade 2, and only 0.8% of the 1.2% of the pneumonitis was grade 3 or grade 4, which required either stoppage of therapy or additional treatment. Now, we have to understand that stage 3 comprises of diverse range of disease presentation. Only selected patients of stage 3B can be operated, and according to UK audit data of 2017, less than 22% of the stage 3A patient and less than 5% of those presented with stage 3B received surgery as a part of the treatment. So, coming to the pros and cons of neoadjuvant versus adjuvant. So, obviously, the benefit is you use the operative, you treat the micromets, you increase the efficacy, you reduce the immune escape mechanism which can happen. The cons of using peri-op is there is a 15 to 20% cancellation of surgery which is mentioned. However, even those not planned for a neoadjuvant therapy, almost 10 to 15%, 10% of the patients cannot go for surgery despite resectable status in view of fitness or delay in surgery. So, which patient stage can be considered for peri-op? So, patients whom we can give R0 resection as a treatment modality, whom there is N2 and resectable status present, peri-op mortality expected is to be low. For selected patients with T4N0, in which MDT suggests that there is a possibility of resection by size as well as extension. As per NCCN guidelines, option of Durva plus chemo has been added now with other regimens for peri-op therapy. So to conclude, peri-op immunotherapy is a promising approach for early stage lung cancer patients. It has potential to improve outcomes and reduce the risk of recurrence. The benefit of peri-op approach over neoadjuvant is yet to be confirmed. However, the numbers seem to be promising. The landscape is evolving rapidly with a lot of multiple trials yet to come with mature results. So thank you very much.
Thank you, Dr. Kodesha, for taking us through the evolution of improvement in treatment in the resectable CA lung. Next, I would like to invite Dr. Arjun Mandade regarding optimization of use of TDM1 in Indian patients. I would like to ask Dr. Arjun.
Can I share my slides? Yeah, am I audible?
Yes, sir. You can share the slides.
Hello. Am I audible and visible?
Yes, sir, you are audible, but your sound is equal. You will join with two device?
Actually, yeah.
Yeah, so you can left with one device, sir.
1 second. Can you take the charge of your slides? Hello.
Yes, Arjun, you are audible.
Yes. Can you show me the slides?
Sure, sir. Sure.
Yeah, thank you. Yes, so good evening, one and all. Thank you, organizing committee, for giving this opportunity. Today, I'm going to speak on optimizing the use of TDM1 in Indian patients. We are already running late, so I'll just run through the slides, which are most important for us. So, TDM1 is approved in adjuvant treatment patients with HER2 positive early breast cancer who have residual invasive disease after neoadjuvant taxane and trastuzumab based treatment. And the second indication is metastatic breast cancer where previously received trastuzumab and taxanes separately or in combinations, and patients should have either received prior therapy for metastatic disease or developed disease recurrence during or within 6 months of completing the adjuvant therapy. Next slide, please. So the update has come, the 7-year IDFS data, and we are just will brush the update of TDM1. Next slide, please. So this is a Catherine study where the prior neoadjuvant therapy consisting of minimum 6 cycles chemotherapy and minimum 9 weeks of trastuzumab, and second HER2 targeted agent was allowed. And the residual invasive tumor in breast and axillary nodes were considered with randomization within 12 weeks of surgery. And there were total 1,486 participants were randomized to 1:1 who received TDM1 3.6 milligram per kg 3 weekly for 14 cycles versus trastuzumab 6 milligram per kg every 3 weeks for 14 cycles. And the primary endpoint was the IDPS, and the secondary endpoint was IDPS with second primary non-breast cancer, including that is DFS, OS, DRFI safety, and quality of life. Next slide, please. So this update has come with a median follow-up of 8.4 years, and there is a big improvement over standard of care. There is absolute IDPS benefit is of 13.7% at 7 years. With a TDM1, it is 80.8% of IDPS versus 67.1% in trastuzumab. So there is a significant difference in IDPS. That is the latest update after a median follow-up of 8.4 years. Next slide, please. So the interim OS analysis was done in 2023, and the updated OS has come, which is TDM1 is the first therapy to show significant OS improvement in this setting, which is absolute OS benefit is 4.7% at 7 years. And at 7 years, the TDM1 OS rate is 89.1% versus trastuzumab, it is 84.4%. Next slide, please. So TDM1 has shown the promising results even in the patient with small residual disease. You can see in the red where the primary residual tumor is less, and the total number of patients were more. The total number of percentage who are having benefit is more when there is a minimal residual disease, and the residual disease less than 1 centimeter with negative axillary nodes also had a significant IDFS benefit compared with the TDM1. Next slide, please. So with great power comes great responsibility. So while using TDM1, how to keep a balance of safety and efficacy, we'll see through the slides. Next slide, please. So the safety data in the TDM1, approximately there were 740 patients, and in trastuzumab arm there was 720 patients. So adverse events were approximately 731 patients, and which was like 98.8% and 672 in 93.3%. But the serious adverse events, these were predominantly causing the discontinuation, where 133 patients, that in 18% versus 15%, 15 patients, that is 2.1%. And the significant side effects which were leading to treatment discontinuations were platelet, that is thrombocytopenia, increase in blood bilirubin, increase in SGOT-SGPT, peripheral sensory neuropathy, and decrease in the ejection tract. Next slide, please. So we'll see the difference in the safety between Asia and global population, because Asian patients are not as equal to the all global population. So we have a study. Next slide, please. So we have a study where we have compared the global in cohort 1. There are global patients which are approximately 2,000 patients, and in cohort 2 there are Asian patients which are approximately 181 patients. And the 70% of patients had more than 2 previous treatment lines in the metastatic setting, and median follow-up was approximately 20.6 and 15.1 months for respective cohorts. So the objective was to evaluate the TDM1 safety and tolerability specifically in the Asian population. Next slide, please. So you can see in the cohort 1, which is a global one, which has a most side effects concerned to the like fatigue, asthenia, headache, and epistaxis, where a relatively lesser side effect like thrombocytopenia. But if you see in the cohort 2, that is 27% patients had thrombocytopenia compared to 8.7 in global compared to global patients. So Indian population are having a majority of thrombocytopenia events were resolved within 15 days in the Indian population, and Indian populations are more prone for the thrombocytopenia. Why? We'll see the mechanism in next slides. So more than grade 3 thrombocytopenia patients were able to continue to DM1 with the dose modifications, and grade 3 or more thrombocytopenia was not associated with higher risk of more than grade 3 hemorrhage events in cohort 2. So the PFS and OS almost similar in the both cohorts. Next slide, please. So the mechanism why Indian populations were having more thrombocytopenia was there is a major, minor, and some unclear mechanism. So in major mechanism, it's a target dependent FC gamma receptor binding to A and pinocytosis, which leads to the change in the 3D structure of TDM1. So Asian patients with a pre-treatment platelet count of 1 to 2.2 lakhs had the highest risk of grade 3 or more thrombocytopenia. Given that the FC gamma receptors like to play a role in TDM1 mediated thrombocytopenia, a specific FC polymorphism that occur more frequently in Asian patients might account for a higher incidence of thrombocytopenia in this population. Next slide, please. So this is a real world data of TDM1 of a biosimilar Ujvira, and safety and efficacy of the biosimilar TDM1 was compared to the original molecule, and you can see the in adjuvant and in advanced setting, the predominant side effect was the thrombocytopenia, which was 25.5% and 17%, along with side effect like fatigue, nausea, anemia, and neutropenia. So most thrombocytopenia are grade 1 and grade 2, and 5 patients were managed by romiplostim for thrombocytopenia, and with the overall response rate of approximately 50% with median PFS of 8 months. Next slide, please. Efficacy and safety of TDM1 biosimilar in the treatment of HER2 positive metastatic breast cancer was studied. That is the biosimilar of biosimilar Ujvira in 6 hospitals from southern India, where there were 72 patients, and second line metastatic breast cancers were 75% patients with overall response rate of close to 50% with median PFS of 9 months. And thrombocytopenia was the major concern, and 33% had all grade, with 7% having more than grade 3 thrombocytopenia with the LFT abnormalities of approximately 22%. Next slide, please. So ways to balance the safety for optimizing the efficacy of benefit, and we are using multiple medicines, and we are taking care that the platelet count should not allow us to discontinue the medicine. So there is a NCCN guidelines where we are using hematopoietic growth factors, and we are like routinely using romiplastim, and it is giving a good increment in the platelet count, which is not allowing to discontinue the therapy. Next slide, please. So there is a data regarding the romiplastim, and the definitions where the that thrombocytopenia varies, and usually it is less than 1 lakh for 3 to 4 weeks following the last therapy administration, and or following the delays in the chemotherapy initiation related to thrombocytopenia. So there is insufficient data available to support the use of TPO receptor antibodies other than romiplastim for chemo-induced thrombocytopenia. So primarily we are using romiplastim to maintain the dose schedule and intensity of chemotherapy when such benefit is thought to outweigh potential risk. So romiplastim dosing there are multiple dosings we are using according to the individual, according to the patient to patient basis. So weekly dosing is there, 2 weekly is there, 3 weekly is there. So usually weekly to begin with 2 to 4 mcg per kg and increase to not more than 1 to 2 mcg per kg per week to target platelet count, at least more than 1 lakh to 1.5, and maximum dose is 10 mcg per kg weekly per prescribing information. So it is uncertain whether use of TPO receptor antibodies for chemo-induced thrombocytopenia increase the risk of VTE in patients with cancer. So caution is always warranted. Next slide, please. The challenge is if the patient is responding well to anti-HER2, but thrombocytopenia is bothering to consecutive cycles, then how to tackle the therapy as well as how to weigh the risk and benefit ratio. So let's look at one case series which is ADC specific. Next slide, please. So this was the study published in 2023 where 6 individuals treated with TDM1 or TDXD who developed therapy-induced thrombocytopenia that required treatment delay or reduction in the dose intensity. And the individuals had a good disease control on their HER2-targeted ADC and subsequently received treatment with romiplastim at the discretion of their medical team. So all 6 patients could continue the treatment with this supportive treatment. Next slide, please. So these are a couple of studies where you can see the TDM1 after TDM1 in second line, third line, fourth line, the delays in the treatment and dose reductions. So definitely in the dose reductions and delays are more in the Asian population. You can see there are almost 3 delays and 3 dose reductions compared to the whites where there is a delays and dose reductions are less. As we discussed previously, in Indian population, there is a risk of thrombocytopenia compared to the Western population. And also studies are proving the fact that Indian populations need romiplastim and TPO receptor antibodies to maintain their platelet count compared to the Western population. Next slide, please. So these are the a couple of cases where is the case 1, case 4 and case 6. The blue line is a platelet count. The blue point is where the romiplastim was administered, and the orange point is when the TDM1 was administered. So in the case 1, you can see from the day 0, 250 mcg every 3 weeks, the romiplastim was given, and you can see the maintained graph of a platelet approximately more than 1 lakh for most of the cycles. In the case 4, the romiplastim was given 250 mcg every week, and every week they have given 125, sometimes 250, sometimes 125. And you can see there is a variation in the platelet count, but majoritarily the platelet count is hovering somewhere around 60 to 80 lakhs, 80,000. In the case 6, where you see the romiplastim was given weekly, that is 100 mcg and 150 mcg, and there is a plateau after 2 or 3 cycles, and the platelet count is persistently more than 1 lakh. So this is the important to know that whether when we are giving TDM1, we should always consider romiplastim from day 0 to maintain the platelet count, because it is expected to have a thrombocytopenia in subsequent cycles. Mostly second or third cycles, they will start having thrombocytopenia. So next slide, please. So the summary, we are in adjuvant TDM1 long-term data has demonstrated the biggest benefit seen in non-PCR patients so far, and it is well established for metastatic breast cancer in our country, and there is an access challenge in newer options. There are difference between global and Asian patients in few ADRs while using antibody drug conjugates. We should keep monitoring the safety aspects and take necessary steps to make patients adherent and derive the optimum benefit. Appropriate baseline counts, dose delays, dose reductions, judicious use of romiplastim, etc. These are important things when we are considering TDM1 in adjuvant and metastatic setting. Thank you. Thank you so much. Any questions, please?
Thank you, Dr. Arjun, for sharing your experience regarding the usage of TDM1. So moving ahead, I would like to invite Dr. Ishu Gupta, practicing in Fortis, Noida, regarding the landscape, regarding the landscape of HER2 positive carcinoma breast. Over to you,
Hello.
Dr.
Hello.
Yes, Ishu.
Hello. Hi. Am I audible?
Yes, you are. You are audible.
Yes, sir.
Thank you to organizing committee. Thank you, Dr. Sahil, for giving me this opportunity. As I've been told, the time is little short. I'll rush through the presentation. and would be discussing about the role of present and future landscape in the breast cancer management, which is HER2 positive. Most of these slides have been previously discussed by previous speakers. And so quickly rushing through, breast cancer incidence is increasing, probably because of increased risk factors as well as the increased use of screening mammograms. And hence, about 25% patients that we see in our clinic, as my experience also goes, is about HER2 positive. In the neoadjuvant setting, as a clear category 1 NCCN guideline, if any patient has a tumor more than 2 centimeters, is node positive, the patient should go for the first chemotherapy, that's the neoadjuvant. And the chemo should be a dual anti-HER2 that includes trastuzumab as well as pertuzumab. This was kind of put in place by a few Neosphere and the Trifina study, which said that the PCR rate is much higher when you combine pertuzumab with trastuzumab and chemotherapy. So as per the NCCN 2024 guidelines also, all the neoadjuvant and adjuvant HER2 positive chemotherapy guidelines are non-anthracycline based, and category 1 is to include pertuzumab also. Future, as per the Fergen study, which is very interesting study design trial in which we are trying to avoid chemotherapy altogether in patients who are HER2 positive, stage 1 to stage 3A. Patients are given anti-HER2 dual blockade with hormonal therapy, and after 2 cycles assessed by the PET, if there is a response, patients are given the 6 cycles of anti-HER2 dual blockade followed by surgery. And if not, then the patients go ahead and receive their TCHP. This was in turn compared by the TCHP group A. So it was found that in the group B, that is about 86 patients were able to finish the 6 cycles of neoadjuvant therapy without chemo. And of these 86, the survival at the end of 3 years, which is interim, was about 100%. So about 1 in 3 patients who were HER2 positive were able to uh, uh, kind of just go through without chemotherapy the whole treatment, and that was much a big gain for HER2 positive early breast cancer patients. In adjuvant therapy, again, the affinity trial did establish that even after 8 years, the benefit between the pertuzumab dual blockade versus trastuzumab arm, the benefit was minuscule. And when this was seen in the node positive patients, this benefit did show a 4.9% improvement in the event-free rate. So in patients who are node positive, pertuzumab should be added in the adjuvant setting, and that is what we do in the clinical practice also. So patients who do get neoadjuvant therapy and do not get a PCR, that is about 50% patients, about 40 to 50% patients. The Catherine trial did very clearly show that adding TDM1 to these patients would result in much greater benefit. Peony trial showed that in the Asian population also, pertuzumab is well tolerated, and the results were very similar to the previous trials. In future, we are trying that a first-line trastuzumab deruxtecan comes up in the metastatic setting, in the recurrent setting. Then, as per the attempt 20 study in early breast cancer, which is stage 1, we are trying that after the APT trial, which is the standard of care today in these patients who are HER2 positive. We are trying that without chemo, patients should get TDM1 and followed by Herceptin for a year. Then there is the Compass HER2 scheme, which is evaluating that patients who do not get PCR after the TCHP neoadjuvant should be given rather than TDM1 only a combination of TDM1 with tucatinib. As of metastatic setting, it is very clearly established that Cleopatra, which was established by the Cleopatra trial, that Trastu dosi with pertuzumab is the standard of care here. And the 5-year survival, the survival rates which we used to talk about in the terms of 1 or 2 years were now being talked about in the range of 5 to 6 years, with the median number of cycles being 24, median PFS being 18 months, overall response rates of 80%. we can see that at the about 95 months, 8 years, that is, we have 37% patients who are alive. So it's very, very clear now that patients who are metastatic first line, although currently is TCHP, we are also going ahead and evaluating the role of trastuzumab, pertuzumab, and eribulin in the first line, which was a which said that the PFS was better in the eribulin group, and if not better, at least comparable to the Cleopatra group when Prastu Pertu were combined with eribulin. Also, Destiny Breast 09 is evaluating the role of trastuzumab deruxtecan in the first line setting in metastatic HER2 positive breast cancer. So let's see. But as of now, as of today, Cleopatra remains the king or the queen, I should say, and TCHP is the clear choice standard of care in the clinic today. Thank you.
Thank you, Dr. Ishu, for taking us through the landscape of HER2 positive CA breast.
Thank you.
Moving ahead, I would like to invite Dr. Jaikumar Patel on the role of avelumab in RCC, advanced RCC. Over to you, Dr. Jai Patel.
Hello, am I audible?
Yes, sir, you are audible.
Yeah. Is my screen visible?
Sir, kindly do share screen.
Yeah, I have shared the screen.
Oh, not visible, sir. Technical support, can you guide, sir?
Yes, can you please come to the Zoom, sir?
Yeah, I am on the Zoom.
Yeah, now your screen is visible. Can you please share the presentation?
Yeah.
Yes,
Now
sir.
is it visible?
Yes, sir. Please
So we can
continue.
start?
Yes, sir. Please continue.
Yeah. So the topic for today's webinar given by Mark is role of avelumab in management of renal cell carcinoma. And I think it's not moving. Slides are not sharing.
Sir, we can share your
somebody...
slides.
Yeah, you can share for me because it's not moving right now.
Sure, sir. We can share your slide.
Yeah. Yeah, second slide, please. So the first line treatment remains an area of unmet medical needs in advanced renal cell carcinoma. The only 51.4% patient receive second line therapy and 48.6% patient do not receive any second line therapy. So we need to optimize the first line treatment approach for better results in advanced renal cell carcinoma. Next slide. So there are multiple TKIs, that is targeted therapies tablets available for the treatment of metastatic renal cell carcinomas along with immunotherapies. Cabozantinib, lenvatinib, sunitinib, earlier bevacizumab and everolimus temozolomide were also used. The newer drugs which are HIF inhibitors are belzutifan and CAR T cells are in research work right now. Next slide. So this is the landscape of evolving treatment of the first line metastatic renal cell carcinoma. Earlier you used to treat with interferons, then pazopanib, bevacizumab, then multiple immunotherapy agents and TKIs came into the market. And as the new drugs are becoming more available, the survival has gone significantly up from less than a year to more than 48 months. Next slide. So first line systemic therapy is recommended for patients with stage 4 or relapsed renal cell carcinoma with clear cell histology, and immune checkpoint inhibitor based combination is the first line treatment who are eligible for systemic therapies. So the agents which we use are nivolumab, pembrolizumab, evolumab, nivolumab. Along with combinations we can use along with in TKIs or dual immunotherapy. So multiple trials have been conducted from 2016 to till date, and FDA approvals have been available for multiple of these drugs. Next slide. So we have to, there are two options, either to go with TKS, which have low impact options, and Minimas is the first. And better is for rapid control, we have to use immunotherapy plus TKI, that is grabbing the neck. Next. So patients, any patient deserves to have rapid disease control, best chance to control, and to prevent frequent hospital admissions. Next slide. Next. So efficacy, safety, and practical consideration are most important for choosing the first line treatment. That patients and disease factors which we need to consider are risk stratification, comorbidities, histological features like sarcomatoid or renal clear or non-clear, prior nephrectomy. Efficacy wise, we have to look ORR, OS, safety, immune related, and there are considerations, availability, option, quality of life, dosage frequency. Next. So combination of Bavencio, that is evolumab with axitinib, has shown to have synergistic action, and VGFR inhibitors like axitinib act on all the known receptors implicating in pathological angiogenesis, lymphoangiogenesis, tumor growth, and cancer progression. And Bavencio has been shown to release the suppression of T cell mediated anti-tumor immune response, and also induce NK cell mediated direct tumor cell lysis via the ADCC. Next slide. So this is the Javelin Renal 101 trial. Next. So in this 886 patients were randomized for first line treatment of advanced renal cell carcinoma with clear cell component, and Bavencio was given by 10 milligram per kg intravenously every 2 weeks plus axitinib 5 milligram orally twice daily, versus the standard of care at that time, sunitinib 50 milligram orally once daily, 4 weeks on, 2 weeks off. The primary endpoints were progression-free survival, overall survival. The follow-up duration for the trials, Javelin trial was followed for 73.7 months, so which is highest as compared to the Keynote and Checkmate 9 ER. Next. So Bavencio plus axitinib versus sunitinib, the patients were stratified equally depending upon the IMDC prognostic risk factor and MSKCC prognostic risk factor. Next slide. So there was significant progression-free survival benefit with 34% risk reduction and almost double overall response rate compared to sunitinib. The evolumab plus axitinib, the PFS was 13.9 months versus 8.5 months with sunitinib. Next slide. The longest follow-up of 73.7 months in IO plus TKI, higher median overall survival with curves continue to separate till the end. So the median overall survival is 45.8 months versus sunitinib 38.9 months. The final OS readout will better reflect the effects of the later lines of the treatment. This has been observed for all the phase 3 trials of first line IO plus TKI in advanced renal cell carcinoma. Next slide. So the high proportion of the patients in sunitinib arm received subsequent PD-L1 inhibitor treatment. So even after sunitinib, when there was progression, the patients received multiple immunotherapies post sunitinib. Next slide. So the real world studies have also confirmed the effectiveness and the safety of first line evolumab plus axitinib. First line axitinib, and the overall response rate during different studies which were real world in UK and Japan showed benefit with median PSM phase ranging from 17 to 12 months. Next slide. Avelumab plus exitinib was well characterized safety and tolerability profile. So the grade 3 side effects were similar in avelumab plus exitinib versus sunitinib, and infusion related reactions of any grade were more in 127 because avelumab is an infusional drug. High dose glucocorticoids, that is 40 milligram per daily dose of prednisone equivalent, were administered because of higher, that is immune related adverse events in 14.5% patients treated with avelumab plus exitinib. Next slide. So the long-term safety profiles of avelumab plus exitinib was consistent with previous analysis. Diarrhea was common side effect followed by hypertension and fatigue. Next, the overall and disease-specific health-related quality of life were generally stable in both the treatment arms. Next slide. So, managing complex immune-mediated or TKI-mediated adverse events, combination therapy with IC, that is immune checkpoint plus TKI, can add complexity to toxicity management because some ICI associated AEs are similar to those associated with TKIs. Immune checkpoint inhibitors therapy is associated with immune related AEs and that can impact multiple organ systems and are often caused by non-specific activation of immune system. Angiogenesis agents can cause toxicity through various mechanisms that are not immune mediated. Next slide. So there are multiple options to choose. Right option from the right patient is important. So more conservative and budget friendly is TKI alone or active surveillance. And the other options are TKI plus IO or IO plus IO. Next slide. So this is the first line IO combination trials in metastatic renal cell carcinoma. So the almost 12 months OS were similar of 83% to 90% in all the studies of immunotherapy. Next slide. The overall survival of cross trial comparisons. So avelumab plus exitinib showed good results as compared with pembrolizumab plus exitinib. Next slide. So depending upon the risk stratification, IO plus TKI combination therapies, risk stratified intermediate or poor risk, favorable risk can have IO plus TKI, favorable risk with coexisting medical monotherapy with TKI or IO, and combination treatment of dual IO or IO plus TKI in intermediate or poor risk. Next slide. So against the different immunotherapies, the in favorable arm the results were similar with 77 to 70%. In poor, the 21.32 versus 11 with javelin avelumab plus exitinib. Next slide. So next slide. There is window of opportunity for treatment in these patients. First line metastatic. Receiving subsequent treatment is 46.6%, and drop of patients of from subsequent line from second line it was 60.5. Next slide. So the favorable IMDC risk group shows benefit when treated with IO plus TKI compared to TKI alone. This is study from United Kingdom. The overall survival were better with IO plus TKI versus TKI alone. Next slide. So favorable, as per IMDC criteria, divides renal cancer into favorable, intermediate, and poor. Avelumab plus exitinib can be a good choice for favorable and poor risk patients, and we can use TKI versus immunotherapy plus dual immunotherapy plus immunotherapy plus TKI. Next slide. So the plasma half-life is very less of exitinib as compared to other TKIs due to the short life. Plasma concentration rapidly decreases following treatment interruptions, which support therapy management of IO plus TKI combination therapy. Next slide. So highly specific TKI, exitinib is also a very highly specific TKI, only acting on VGF and inhibitors and not inhibiting other inhibitors and other receptors like ROS, MET, or KIT. Next slide. So IO plus TKI has a overlapping toxicity. Exitinib with a shorter half-life supports therapy management easily, and the overlapping conditions can be treated quickly. Next slide. So the avelumab half-life is approximately 6.1 days and exitinib 2 to 6 hours. The other immunotherapy or other targeted therapies have longer half-life. Next slide. So exitinib dose interruption or reduction can rapidly resolve toxicity, and most immune-related adverse reactions associated with avelumab were reversible and managed with temporary or permanent discontinuation of avelumab administration of corticosteroids and supportive care. Next slide. So again, the combinations have almost similar efficacy across all the trials involving the immunotherapy plus TKIs. Next slide. And the adverse events were similar in all the immunotherapy plus combinations. Next slide. So in summary, selecting the right treatment for advanced renal cell carcinoma is crucial. And for favorable risk, we can use avelumab plus exitinib. And poor risk also, we can use avelumab plus exitinib. Safety-wise, avelumab plus exitinib has lower discontinuation, steroid use, and better pulmonary safety. Subgroup better outcomes with avelumab exitinib for patients with sarcoidoid components and those of end-stage renal disease undergoing dialysis. Next. Thank you.
Thank you, Dr. J. Patel, sir, for sharing your insights into the management of RCC. It has lots of options, but selecting the right combination for the right risk is important. And most of the patients have comorbidities for the subgroup, and these have to be taken into account. So
Thank
moving
you,
ahead, I
Sai.
would like to invite Dr. Darshit Shah, sir, for taking us through the landscape of management of hormone receptor positive, HER2 negative metastatic breast cancer. Over to you, sir.
So, thank you for the kind invitation and thank you, Novartis, for giving me the opportunity. If somebody can share the slides from their end. Perfect. So, reviewing the first line treatment landscape for hormone positive, HER2 negative advanced breast cancer. Next, please. Next, please. So complexities in first line clinical decision making. Now we are spoiled by plenty of choices. The primary treatment goals are impact on quality of life, prolonged survival, disease characteristics, presence of aggressive features like visceral crisis, visceral mets, critically aggressive disease, or response to prior treatment. That is advanced setting is CDK4/6 inhibitor plus endocrine therapy, ET or chemotherapy. Next, please. So the current treatment guidelines, I would say all of us, I would say 100% now are using first line CDK4/6 inhibitors plus endocrine therapy in all our patients with advanced metastatic breast cancer. If the disease progresses, if the patient has somatic mutation of BRCA or germline mutations, we tend to have different options. If germline, then I would prefer olaparib as PARP inhibitor. Now it's very accessible now, all thanks to generics available. If there is no organ failure, we have second line of fulvestrant plus CDK4/6 inhibitor or everolimus exemestane or PIK3CA mutation is there, then we have to combine alpelisib along with fulvestrant. Next, please. So this is a reference case in which patient with advanced breast cancer who was hormone positive, HER2 negative, 64-year post menopausal female. The disease characteristics, initial diagnosis, hormone positive, HER2 negative EBC, treated with letrozole in adjuvant setting. Disease recurred within a span of 2 years after she completed adjuvant ET. Next, please. So the treatment guidelines, all of us would agree that it's now not chemotherapy now, it's endocrine therapy with CDK4/6 inhibitor. So the 64-year-old postmenopausal woman treated with adjuvant letrozole. Now the disease recurred as advanced breast cancer after she completed adjuvant endocrine therapy. So the first choice would be to give fulvestrant and to add CDK4/6 inhibitors. Next, please. So the treatment options, there are three approved CDK4/6 inhibitors. All of us are aware. I would not name them. They are in the market since a long time. So disease characteristic, initial diagnosis of hormone positive HER2 negative EBC in adjuvant setting treated with letrozole, and disease recurred nearly 2 years after she completed adjuvant ET. Next, please. So the criteria when we talk about Mona Lisa, Monarch, or Paloma. So no, this is the when we talk about the Paloma and the Mona Lisa trial, they actually included the relapses less than 12 months after end of neoadjuvant endocrine therapy. So the DFI across the trials was Mona Lisa time from initial diagnosis to disease occurrence. In Paloma, it was time from end of neoadjuvant treatment to disease recurrence, and in Monarch, it was time from end of neoadjuvant to disease recurrence. Okay, next, please. So the current standard of care, I would say all of three are current standard of care. We all have a very good PFS data in Mona Lisa, in Paloma, and in Monarch trial. The hazard ratio of Mona Lisa are quite impressive, 0.56. Next, please. So we can see that the OS from clinical trials in post-menopausal women, they have actually favored Mona Lisa, that is ribociclib plus letrozole. Abemaciclib is just touching that center, and I would say palbociclib has not actually, shown to have a clinical benefit when it comes to the OS. The significance has only been achieved with the ribociclib, the Mona Lisa trial. Next, please. So the talking about adverse effects, the neutropenia is usually which we what we see with ribociclib. All grades neutropenia around 74%. But although palbociclib also causes nearly significant neutropenia, abemaciclib is known to cause lesser neutropenia. But yes, diarrhea is a significant problem with abemaciclib, which is less common with the ribociclib. Next, please. So maintained health related QL, clinically relevant improvement in pain score, statistically significant delayed TTD, improving or worsening diarrhea score, everything it was actually achieved with Mona Lisa. First thing is health related QL and improvement in the pain score. The patients when they come to me, the primary thing which they always want is आप मेरा disease कम करो ना करो, you please control my pain. So that was actually achieved with Mona Lisa with ribociclib as well as letrozole arm. Next, please. So this is the key guidelines. I think ribociclib plus AI is a category 1 recommendation in NCCN. Abima and palbociclib are category 2A recommendation. So all of us have the maximum experience with ribociclib in advanced breast cancer. And personally, me, I usually prefer ribociclib because of very strong data and very significant experience of all the clinicians in our country and across the globe. Next, please. So, points to ponder: how do efficacy, safety, and QoL data impact your clinical decision? So, this is a 64-year post-menopausal woman. The disease recurred as ABC 2 years after she completed adjuvant ET. Next, please. So the patient is a clinically aggressive, high risk burden ABC. So what additional evidences do we have to CDK4 inhibitor patient? This is a clinically aggressive, high risk disease burden cases because a hormone positive disease recurring in 2 years. It's a aggressive, variant. Whatsoever it be the ERP or HER2 status, it's an aggressive disease which we are dealing with. Next, please. So the right choice study design in which symptomatic visceral mets rapidly progression disease, sort of aggressive variant, markedly symptomatic non-visceral disease. They were randomized into chemotherapy versus ribociclib. The primary endpoint was progression-free survival, and secondary was overall survival and overall response rate. Next, please. So we can see that, yeah, I mean, everyone was skeptical initially. We were using chemotherapy in patients who were aggressive disease and in fact visceral disease, but this right choice study showed that a significant benefit of PFS of around 11.7 months over combination chemotherapy directly in aggressive hormone positive, HER2 negative advanced breast cancers. We can see that the curves start separating as early as 6 months and it continues to separate throughout. The numbers are 24 versus 12.3. It's a huge, huge difference. Huge difference. P value is 0.0007 and hazard ratio is 0.54. Next, please. So we can see that the overall response rates and time to recurrence was non-inferior to combination CT. In fact, ribociclib plus ET is better when compared with chemotherapy. Chemotherapy comes with a lot of side effects. We all of us are aware. Next, please. So we always, what's there in the West, it's not always replicated in Asian. So do we have a data of Asian data with CDK4 inhibitor, clinically aggressive, high risk disease burden? Next, please. So the post hoc analysis of Asian and non-Asian patient from phase two right choice study, we can see that Asian subgroup included patient with Asian race only. Next, please. We can see that Asian and non-Asian, we have actually had a well-matched population, and the symptomatic visceral mets and non-visceral disease symptomatic, they are well balanced in both the groups. Next, please. So the PFS with ribociclib plus endocrine therapy, we can see that the PFS was 25.2 versus 11.2. When we talk about the Asian population, in non-Asian also it was significant. But I would like to point out here that Asian population had a significantly better response. Next, please. Next, please. Safety profile was consistent throughout. The predominant side effects were transaminitis, alopecia, nausea, vomiting, fatigue. So nothing is there which we cannot, manage. Predominantly, there was neutropenia, anemia, and leukopenia, which we encounter in our day-to-day practice for all, for predominantly our ribociclib patients. Next, please. So the right choice trial with ribociclib reinforces that CDK4/6 plus ET as a standard of care for first line therapy across patient profiles. Next, please. So this is a clinical aggressive, high risk disease burden patient. Next, please. I would like to choose ribociclib. It's ease. It's very easy to take 3 tablets rather than to take multiple chemotherapy intravenous with significant toxicities. Next, please. Yes. So ease in explaining overall survival, ease in titrating the doses. We have 200 milligram tablets. We can titrate according to our tolerance to our patients. Next, please. Ease in ensuring good efficacy while maintaining quality of life. Next, please. Next, please. So with this, I would like to thank you. Thank you, Dr. Sahil. Thank you, Novartis, for giving me the opportunity. Thank you so much.
Thank you, Dr. Darshit sir, for taking us through this complicated topic in which we are spoiled for choices. So we conclude today's event. I want to take a moment to express my heartfelt thanks. First and foremost, thank you to our distinguished speakers for sharing your valuable insights and experiences. Your contributions have truly enriched our understanding and inspired us all. Thank you for all your time and dedication. Finally, a special thanks to the organizers and sponsors for making this event possible. Thank you, everyone, and I wish everybody a good night.
Good night, sir. Thank you so much for your time. Technical support.